Hello everyone. Our today's question is related to hemostasis. This case is an acquired von Willebrand case, which can be a case of FRCPath hematology part 1, or it can come in FRCPath part 2, both paper and viva. The recent FRCPath part exam has acquired von Willebrand question, and von Willebrand is a must question in FRCPath Part 2, either congenital or acquired. So you must know about acquired von Willebrand, the different causes and pathogenesis of acquired von Willebrand, and its acute management and long-term management. You can be asked in any section in the Part 2, paper or viva. So we will start with the case. A 69-year-old patient was admitted under urology following a TURB procedure. Post-procedure, there was persistent hematuria, macroscopic, and getting worse day by day. So you will be asked in the viva or in the paper for a few marks that what further questions would you like to ask from this patient in the history. The main purpose of this question is to establish whether this is a congenital condition or a newly acquired condition. So you would ask about the patient, previous history of bleeding, previous procedures complicated by bleeding, family history of bleeding, make a family pedigree if there is anyone in the family affected by bleeding disorders. Basically, these are all the questions that are present in the BET scoring system. So this question mainly focuses on the different points in the bleeding history of any patient. So we took history from this patient, and he mentioned that he does not have any previous bleeding history. He had 2 surgical procedures, one major or other minor, and it was without any bleeding complication. No one in the family is affected by bleeding disorder, and upon examination, he did not show any signs of organomegaly or lymphadenopathy. Why we mention lymphadenopathy or organomegaly here? Because we were expecting an acquired von Willebrand disease or acquired hemophilia or acquired platelet disorder in a patient who has a bleeding history recently and not affected in the past. Then the examiner will give you some bloods, or the scenario in a paper of coagulation will have some blood results for you. So this patient hemoglobin was 83, white cell count 9.93, platelet 366, MCV 88. Coagulation screen shows PT 11 second, INR 0.9, and APTT 54 seconds. So it is quite obvious that this patient APTT is prolonged. So now you have to think about what are the causes of prolonged APTT. So that would be the next question in the paper, either part 1 or part 2 or in the viva. What are your differentials for this case now? Bleeding history and prolonged APTT. So you need to think about hemophilia, von Willebrand disease, heparin exposure. Hemophilia acquired von Willebrand can be congenital or acquired. So if you write the answers in points, it will give you 3 to 4 marks. And if you mention all the options that they have mentioned in their key, you will get 4 out of 4 marks. The next question would be from their side, what further investigations you would like to do for this patient? So if it was a GP sample or if the patient is asymptomatic, I would have said that repeat the coagulation screen in this patient. But this patient is obviously bleeding, and the patient need urgent intervention and assessment. So you can go ahead directly to next step, which is the mixing study to find out whether there is correction of APTT or not. Then you would like to remove heparin effect, so thrombin time, if it is normal or not. Then the von Willebrand screen, which in our trusts include factor 8, von Willebrand antigen, and Rakoff level. And obviously, APTT is prolonged, and you would also think about intrinsic factor assays as well. So once you mention these tests, they will give you the results that you did mixing studies. Mixing study shows no correction. So you are now thinking about inhibitor. Thrombin time is normal. Close fibrinogen is normal. Von Willebrand shows low factor 8, low antigen, and very low Rakoff. Intrinsic factors are normal. Now I think every one of you would have reached to the diagnosis. What is the likely cause of bleeding in this patient, which is acquired von Willebrand disease. So, but what is the cause of this acquired von Willebrand disease? In any acquired bleeding disorder, you have to address the uh, acute issue, which is bleeding, but at the same time, you conduct tests to find out what is the cause leading to this acquired phenomenon. So at the same time, we send the following blood test. Thyroid function test became normal. Autoimmune screen was normal. Hemolytic screen and blood film were normal. Echo and plasma viscosity were okay. Virology screen normal. Protein electrophoresis and immunofixation shows IgG of 5.8 gram per liter. CT cap, no evidence of malignancy. So this patient additional investigation shows a paraprotein of 5.8, which is of IgG subtype. So the final diagnosis in this patient is acquired von Willebrand disease, secondary to MGUS, IgG subtype. Mentioning type of MGUS is important because MGUS can be IgG or IgM, and their management for the acquired von Willebrand disease is a bit different. So the next question that they can ask in the exam would be, what are the mechanisms and pathophysiology leading to acquired von Willebrand disease? Or they can ask you, what other conditions are associated with acquired von Willebrand disease? So, as you know, acquired von Willebrand disease has multiple mechanisms. It can be an autoantibodies that can inhibit von Willebrand. It can be clearance of von Willebrand multimers from the plasma, as we see in the MPNs. It can be cleavage of von Willebrand multimers after shear stress, like we see in left ventricular assist devices. It can be decreased synthesis of von Willebrand, which can be seen in hypothyroidism, or it can be an adsorption phenomena, which you can see in tumors, For example, Wilms tumor in children can lead to acquired von Willebrand syndrome. So, what are the conditions which are associated with von Willebrand syndrome? So, multiple diseases can lead to acquired von Willebrand disease. You can divide it as lymphoproliferative, like CLL, can lead to acquired von Willebrand disease, Waldenstrom, multiple myeloma. So these are the examples of lymphoproliferative. Then you can give another heading of myeloproliferative, like polycythemia, essential thrombocythemia, solid tumors like Wilms tumor, immunological disease or immunologic disease like SLE or mixed connective tissue disorder, cardiovascular causes like aortic stenosis, um, atrial septal defect, drug causes like ciprofloxacin, uh, graziofulvin, valproic acid, they are all implicated in the acquired von Willebrand syndrome. Now, the question is regarding management, which can be asked in both part 1 and part 2. How would you acutely manage this patient? This patient has ongoing hematuria and his hemoglobin is low as well. So we need to address this patient bleeding at the moment. So if he continues to lose blood and he becomes symptomatic with anemia, you have to arrange blood transfusion for the patient if he is not Jehovah Witness. You need to mention this word in bracket, if not Jehovah Witness, because this may be the first time the patient is receiving the blood, and it will show to the examiner that you are aware of NHS system and you know how to proceed in cases of blood transfusion. In this particular case, both factor 8 was low and von Willebrand was low. So for such cases, we usually prefer intermediate purity concentrate. The widely available in our trust is Vocento, which contain both factor 8 and von Willebrand concentrate, and we give it to the patient. This patient needs a very frequent Vocento replacement, 4 hourly, as I mentioned in the answer, because he has paraproteins, IgG subtype, which is inhibiting the von Willebrand multimers. So whatever Vocento you give to this patient, its effect will be very short limited, and you need to replace it very frequently. So for that purpose, to inhibit the effect of these immunoglobulins in the system, you can give the patient IVIG. IVIG takes its effects in 12 to 24 hours. So for 12 to 24 hours, you have to manage the patient supportively by blood transfusion and by giving him frequent Vocento or factor concentrate. Once the IVIG starts its effect, the requirement for the Vocento or an intermediate purity factor will go away. The effect of IVIG remains for almost 4 to 6 weeks, and you will see your patient von Willebrand screen will be in normal range or above normal range for quite a long time, almost 4 to 6 weeks. Obviously, you cannot give tranexamic acid to this patient because he has hematuria, and tranexamic acid is not indicated in such case. If you mention tranexamic acid for such patient in the exam, it will have a very bad impression on the examiner, both in the viva and in the written paper. Urology team has to be involved because he has hematuria and bleeding from the urinary system. So they need to be involved as well. What about the long-term management plan? This section is important. We usually manage the patient acutely, but forget the long-term management plan. That's why we lose marks in the exam, both in the essay and in the paper. And it is a reflection of our practice. We do these things in our practice normally, but due to anxiety or stress, we somehow forget it in the exam and we lose very easy marks. So if there is a management question in the exam, always mention your long-term management as well, so that the examiner know that you are aware how to manage the patient and you can act as a consultant safely. So you investigated this patient for the secondary cause of acquired von Willebrand syndrome, which is IgG subtype MGUS. MGUS usually do not require treatment in the setting of acquired von Willebrand syndrome. But if you see the paper, How I Treat von Willebrand syndrome, they have mentioned that if the patient is coming to the hospital again and again with bleeding episodes because of acquired von Willebrand syndrome secondary to MGUS, then you need to give some type of immunosuppression to the to this patient to treat MGUS. Immunosuppression can be in the form of steroids or rituximab or cyclosporine. It depends on the team involved in the treatment of this patient and on the hospital or trust guidelines. Register the patient with the hemophilia center or tertiary center where this patient will be followed from time to time. Once he is bleeding episodes free for a year or two, then you can safely discharge this patient. But you need to follow this patient after sending him home to see the Meyers and to see if the bleeding has happened again or it's coming back, etc. He has acquired bleeding disorder. So like congenital bleeding disorders, this patient does need acquired bleeding disorder cards. He may be going for another cosmetic surgery or plastic surgery or any type of surgery very soon in another hospital, another area. So that hospital or area or place may not have the patient record. So the patient can present his card to the treating team so that they should be aware and they will contact you for a plan of surgery for this patient. Safety netting is must. In all patients, when we are sending them home, we do safety netting. We give them information leaflet about acquired bleeding disorders, symptoms, and ask them to contact us out of hours or in hours if they have any concerns regarding their bleeding disorder. CNS contacts are important because these patients will contact CNS first in hours if they have any issue. Psychological support is important. A new diagnosis of any bleeding disorder or any type of a major disorder can have a lot of psychosocial effect on a person's mental health. So these patients may need psychological support. If it is indicated, you have to refer the patient for this type of support. And as we mentioned, follow-up clinic appointment is important. This is your patient. You do not give up on this patient after treating them acutely. You have to follow him in your clinic. If you are answering this question in FRCPath Part 2, you are a consultant, this is your patient, you have to arrange appointment for this patient in your clinic. A few points regarding acquired von Willebrand disease. It is indeed rare, but still you will see the patients of acquired von Willebrand disease in your hospital. It can be a quantitative and functional disorder of von Willebrand disease. The patient usually has no family history because it is acquired, and the presentation is usually in the middle age or in the elderly, and associated with other diseases that we mentioned, that it can be associated with lymphoproliferative disease or myeloproliferative disease, can be with solid tumors or immunological diseases. The pathogenesis, we mentioned that it can be secondary to autoantibodies or increased clearance from the plasma in case of proliferative diseases, or proteolytic cleavage of von Willebrand after shear stress in case of cardiovascular diseases like LVOD or aortic stenosis. Decreased synthesis in the case of hypothyroidism or adsorption on the malignant cells. So these are the few pathogenesis of acquired von Willebrand syndrome. You should remember them. They can be asked in the viva for sure, or in the paper, either in part 1 and part 2 as a 3 or 4 marks question. Just like all bleeding disorders, they can come with epistaxis, menorrhagia, GI bleed, postpartum hemorrhage, subcutaneous bleed, or major bleed post-surgery. Our patient has major bleed post-surgery. It can come as a GI bleed as well. If you go to the past paper of FRCPath, you may have seen many patients with acquired von Willebrand syndrome having GI bleed in the form of Hades syndrome, aortic stenosis plus gastrointestinal angiodysplasia. So this is called Hades syndrome. These patients usually have low von Willebrand on von Willebrand screen testing. And then they asked you how to manage this patient. Different causes. In the recent FRCPath exam, there was a question that what are the different causes of acquired von Willebrand syndrome. It was a 4-mark question. Or in another exam question, it was framed like this: what other conditions are associated with the above mentioned disease? Like they have given a scenario of acquired von Willebrand syndrome, and they were asking what other conditions are associated with above mentioned disease. So write it like lymphoproliferative, for example, Waldenstrom; myeloproliferative, for example, polycythemia vera; solid tumor, i.e. Wilms tumor; immunological diseases, i.e. mixed connective tissue disease; cardiovascular disease like atrial septal defect; drugs causes, ciprofloxacin; miscellaneous or others, hypothyroidism. So it will give you full marks. Diagnosis need a thorough bleeding history, a patient personal bleeding history, family history, previous surgeries, whether they were complicated by bleeding or not. Usually the onset of bleeding is sudden and in the middle to elderly age. Majority of the patient you will see they are in the elderly age. And they may have features of associated or underlying disorder as well. For example, they can come with stroke. If if it is secondary to polycythemia or Waldenstrom, they can have features of polycythemia or Waldenstrom. Testing for underlying disease is important um, because when you treat the underlying disease, the chance that this will happen again will be reduced. And then the main diagnostic test. In the initial main diagnostic test is a mixing study, which tells you that this is an inhibitor or not. And then von Willebrand screen, in case of acquired von Willebrand, it will tell you that the RICOF is very low, factor 8 will be reduced, von Willebrand factor antigen will be reduced as well. This question can be asked in the viva, so be prepared for it. The examiner can ask you, can I test an asymptomatic patient for acquired von Willebrand syndrome? Because you have a lot of polycythemia patient, essential thrombocythemia patient, multiple myeloma, all hematological malignancies patients are present, and would you test them for acquired von Willebrand syndrome if they are asymptomatic? So according to BSH, no. In practice, we don't test them. So the answer should be no. Investigations for acquired von Willebrand syndrome. It's the von Willebrand screen. The initial bit we have discussed early, like the coagulation screen, APTT would be high. Then mixing study, it will be abnormal. After that, you have von Willebrand screen and collagen binding activity. Multimer studies. Then for the secondary causes, the cause of acquired von Willebrand, you can do paraprotein, you can do thyroid function test, you can see blood film for any plasmacytoid type cells, or imaging like CT, CAP, chest, abdomen, and pelvis, if there is any lymphoma underlying or not. Now, the management of acute bleed. Tranexamic acid can be given if it is not GI or urogenital bleed. If it is a mild bleed, like epistaxis, mild epistaxis, or bruise on the skin, then yes, you can give tranexamic acid, but it would be not sufficient to give only tranexamic acid. You have to give some more. Desmopressin usually have a short-lived response, and in acquired von Willebrand disease, you need to give more than 2 or 3 doses, which means this patient is at risk of developing tachyphylaxis. That's why desmopressin is not favored in acquired von Willebrand cases. Factor concentrates, which is either von Willebrand factor concentrate or intermediate purity factor, like Ocento, can be given, but as we discussed in our case, its half-life is also less because of the underlying pathophysiology. So we give them frequent factor replacement, and at the same time we give them IVIG as well if the acquired von Willebrand is secondary to immunoglobulins. But remember that in IgM type MGUS, you cannot give IVIG because it would lead to hyperviscosity and complications because of the hyperviscosity. So if you go to How I Treat von Willebrand article, they have mentioned that IVIG is only for IgG type MGUS. IgM type MGUS leading to acquired von Willebrand syndrome should be treated with plasmapheresis. You need plasma exchange for this patient if they are coming with acquired von Willebrand syndrome secondary to IgM MGUS. Bypassing agent, means factor 7 or fever. If the bleeding is acute and there is a delay in the arrangement of factor concentrates and bleeding is severe as well, you can try factor 7 as well. Blood transfusion is supportive because prolonged bleed can lead to anemia, so the patient may need blood transfusion as well. IVIG, we mentioned, plasma pheresis for IgM type, MGUS because of the hyperviscosity, and if there is other causes of acquired von Willebrand disease, like if you have essential thrombocythemia, then do platelet pheresis. If you have um, LVOD as a cause of uh, acquired von Willebrand syndrome, then you need to contact the cardiology to intervene in this patient as well. If it is a drug cause of acquired von Willebrand syndrome, then you need to remove the offensive drug from the drug chart. So this is algorithm from Ash article, if I remember it correctly. So they have shown a small algorithm which says as minor bleeding, you can give DDAP, but if the bleeding is moderate or major bleeding, then you cannot give DDAVP because of the risk of developing of tachyphylaxis. Then you need to give them IVIG and 1 milligram factor concentrate. Still no effect or bleeding is severe, then you can use bypassing agent like factor 7, recombinant factor 7. And if this patient is going for surgery and he has acquired von Willebrand syndrome and the levels are low, better to give them IVIG first, and then in post IVIG, after a week or two, when the levels are optimized, this patient can go to surgery. In the end, I would request to subscribe to the channel. We will be discussing the cases regularly for hemostasis, transfusion, and the morphology sessions are online. If I'm able to record the morphology sessions, I will upload them to the channel. They are weekly for an hour. And my advice would be to practice the question in the exam style. I know all of you have knowledge and better knowledge than me regarding hemostasis or other hematology subspecialties, but exam is a trick and you need to put your answers and knowledge in exam style, then you will be able to clear the exam. You may be knowing a lot of things, a lot more than me, but if you are not putting them at the required place